Welcome to the Parkinson's Foundation Expert Briefings. The event will begin shortly. There will be a short introduction by our moderator, followed by today's presentation. After the presentation, we will address questions from our web audience during a Q&A session. Please note that questions can be submitted by clicking on the Q&A icon in the black banner on the bottom of your viewing page. Due to our limited time, we can only address questions that are most pertinent to the topic. I will turn this event over to today's moderator.
Hi there, everyone. Welcome to our 5th webinar in the Parkinson's Foundation 11th Expert Briefing Series. I'm Dr. Jim Beck, your host, and today's topic is PD and medication, what's new? We're going to be joined by Dr. Fernando Pagan from Georgetown University Hospital, which happens to be a Parkinson's Foundation Center of Excellence. What I want to do before we get started is just orient you to our Zoom screen. Many of you probably are getting very familiar with Zoom now that we're doing a lot of sequestering at home in this time of COVID, but nevertheless, I just want to orient you. At the bottom of the screen, you'll see 3 icons. One is a chat bubble, one is the raise hand, and one is Q&A. The chat is going to be where my colleagues are going to be sending information to you about how to download the slides, for instance. If you would like to get a link so you can have a copy of these slides so you can look at them later on, my colleagues will push that forward into the chat. The raise hand is not something that we utilize, but the Q&A is something we do. And this is going to be where you, as our audience members, are going to be able to ask questions of Dr. Pagan that we can then relay to him and provide that to you. So in the chat, you should see that there will be links that will be provided by my colleagues to push those links for the download, as well as a link for CEU. So if you're a health professional and are interested in watching this presentation for credit, you get 1 free CEU for viewing this webinar. And then you can click on the link that will be posted, and it'll open up another window and allow you to register, ensure you're registered, and for the information you'll need in order to complete your CEU, the test that will occur after this webinar. Remember, you only have 30 days, and that's until April 17th, to collect your free CEU. This webinar is also going to be recorded, so it's going to be available about 2 days later, so you can watch it again if you weren't able to collect everything that you wanted and write it down. So you'll be able to, you'll receive an email when it's available later online. I also want to thank our sponsor, Kiowa Kirin, which has graciously provided support to make our expert briefing series possible. Also, in this time of COVID, I want to highlight something that the foundation is doing. It's called PD Health at Home. Hopefully you've received an email, or perhaps you received a postcard like I did about our virtual education series, which we've designed for people with Parkinson's. And these are events which occur Monday through Friday. Yesterday was a Mindfulness Monday. Today we have our expert briefing series. Wednesday we have Wellness Wednesday. We take time on Thursday to engage with our local chapters. And then on Friday we have Fitness Fridays. So basically we have these Facebook Live events, virtual exercise events, and interactive events that are going to be hosted by our local chapters throughout the United States. So I encourage everyone to go online and register. You just go to our website, parkinson.org/PD Health. That's parkinson.org/PD Health to register, and you can get more information about our wellness programs. And I've got many generous sponsors who've been able to make that possible as well, and really appreciate that support. So one of the things I want to do right now is just push a couple polls forward to just understand who is our audience today. So who are you? So you should see a poll that just appeared. Click on the button and hit submit, and we should be able to get a sense of who's registered and listening in today. We've got 1,200 participants so far, and just want to get a sense for where people are. We've got to go just a few more seconds and see where it goes. Okay, we've got about almost everyone's voted, so let's end our poll and see what the results are. All right, so most of the people are people with Parkinson's, as you would expect, and their care partners. A fair number of health professionals are watching too, about 180. So that's great to see, and some scientists and researchers. Welcome everyone, and some people who are friends of those with Parkinson's disease. So I want to push another poll just to get a sense, where is everyone logging in from? We've got nearly 1,300 people who are here, and just want to get a sense of where people are coming in. Typically, this is 1 o'clock on the East Coast, so I suspect most people are from the United States, and got some from Canada. But this is something that people are listening from all over the world at times. So we're glad to see that, and I think we've got about 3/4 of the people have voted. So let's go on and see where we are right now. Yeah, by and large, most people from the United States. And hopefully everyone is doing well in this time of COVID. So the last thing I want to do is post a poll just to get a sense of what you're interested in as our audience to hear about. We're looking to choose our next series of expert briefings, which will start in September. And we want the feedback from the community to understand what we should prioritize as part of this. We have 6 webinars we typically host, and want to just make certain that what we're doing is reflective of the interests of you, our Parkinson's community. So we're looking to get those coming in. People are given a chance to read and taking a little bit to vote. So we'll just give it a few more seconds more and see where it stands. Getting close to 50% on voting. Okay, I think we can end it now. We've got a lot of interest here and fatigue and side effects, as well as issues around young onset Parkinson's disease and PD and dental health. That's a really important thing, as well as palliative care and women in PD. That's great. Those are topics that are really worth taking a look at as well, as in addition to advanced care planning. Okay, all right, so what I want to do now is move forward with our presentation. I thank everyone for their time to provide that feedback for us. And what I want to do now is get ready to introduce Dr. Fernando Pagan. Dr. Pagan is a professor and vice chairman in the Department of Neurology at Georgetown University Hospital. He's the director of the Movement Disorder Program and medical director of our own Parkinson's Foundation Center of Excellence there. He also is a fellowship director for clinical research fellowship in movement disorders at GU. That is, he is the mentor for many individuals who are looking to become neurologists who take care of people with Parkinson's disease and other movement disorders. Dr. Pagan received his medical degree from Georgetown University and did his internship and residency there as well. He completed his fellowship in movement disorders and magnetic resonance spectroscopy at the National Institutes of Neurologic Disease and Stroke as part of the NIH. Needless to say, he's a board certified neurologist. Dr. Pagan's interests include Parkinson's disease, Parkinsonism, and other related disorders such as ataxia, essential tremor, dystonia, and tics. He's an expert on botulinum toxin treatments for dystonia and tremor, and he's been the primary investigator on numerous clinical trials and is currently leading 15 clinical research trials that aimed at discovering new drugs or approaches to improve the quality of life of patients with movement disorders and neurodegenerative diseases. So at this time, I'd like to welcome Dr. Pagan to our expert briefing and leave it to him to provide us a step to move forward. So Dr. Pagan, if you could turn on your camera.
Yeah. Well, thank you. Thank you so much. Thank you so much for that kind introduction. I'd like to welcome everybody today. We have a big topic to discuss. So I'm very thankful to the Parkinson's Foundation for putting this together. I know these are difficult times. These are different times. We've now been propelled really into telemedicine. So a lot of us physicians are now still seeing our patients through telemedicine. So we're getting used to using Zoom as well as a lot of different platforms. So hopefully today's presentation will be very beneficial to you because there's still a lot that we can do for you, even though we may be more remote than previously before. Because there's a lot going on in Parkinson's and a lot of research still going on. some of the research trials are kind of on hold, but we can still provide that care and that need that you may need, even though we may be far away from each other at this particular time. So it's a real exciting time. Let's talk a little bit about what's new in Parkinson's and what are some of the new medications that we have to help improve the quality of life of our Parkinson's disease patients. So here are my disclosures. I am a consultant for various companies. We are doing a lot of research in Parkinson's disease and other disorders, and trying to find new treatments for, especially disease-modifying treatments in Parkinson's and other neurodegenerative disorders. So if we think back over the last 200 years, not much has really changed about Parkinson's disease. Unfortunately, we still describe Parkinson's mainly as a movement disorder, and this was first described back in 1817. And still, as clinicians, when we first see a Parkinson's patient, it's really the motor features that still defines Parkinson's. And what we're learning is that Parkinson's is much more than a motor disorder. Back in medical school, we always looked at the Lewy body. This is the abnormal proteins that build up in all neurodegenerative disorders. In Parkinson's, it happens to be mainly alpha-synuclein, but there's other proteins that build up as well. In other atypical disorders of Parkinson's, it's misspelled the protein tau. In Alzheimer's, it's tau and beta amyloid. But what we've learned is that Parkinson's is much more just in the substantia nigra. Parkinson's is really more diffuse. This abnormal protein, if you only look at the substantia nigra, that's really just the tip of the iceberg. Alpha-synuclein is involved pretty much diffusely, both in the central and the peripheral nervous system. And if we go back to 2003, when we first started to learn about the evolution of how this misfolded alpha-synuclein is deposited along the brain, we've now learned that it's probably beginning more peripheral, probably the gut, and then it's absorbed into the brain. It begins at the lower brain stem, and then goes more towards the top, more up towards the top of the brainstem, and then eventually evolving the cortex as well. And some of the earlier signs and symptoms can be constipation or difficulty identifying certain smells. And what we've learned is that this evolution takes many years. So we could see multiple non-motor symptoms present before the motor symptoms of the disease. So constipation, smell identification problems, mood disorders, sleep disorders sometimes can be present years before the motor symptom ever shows up. And there are a lot of non-motor features that we see in Parkinson's disease. So we see a lot of neuropsychiatric and cognitive problems in Parkinson's, and these are non-motor features. We see a lot of autonomic dysfunction. Again, the constipation is one, but we can see drooling problems. We can see blood pressure problems like orthostatic hypotension. When you're standing for a long period of time, your blood pressure drops. Sensory problems, so not only the smell loss, but pain. Pain is often a presenting symptom of Parkinson's. A lot of individuals with shoulder pain, calf pain, back pain, just early morning cramping pain in the calves, in the legs, etc. And these are things that are not always identified as Parkinson's very early on. So there's a lot of non-motor features. So now we really understand that Parkinson's is both a non-motor and a motor disorder. And if we take a look at this particular slide, I don't know if you can see my arrow, probably not, but what we've traditionally done in Parkinson's and as movement disorders is the third graph all the way to the right. That's when we really start seeing patients. We identify Parkinson's when the motor features are there. But as you can see from this graph, there are non-motor symptoms that can be present from anywhere from 4 to 20 years before these motor symptoms really arise. So as movement disorder neurologists, not only are we treating the motor disorder, but we are also treating the non-motor disorder as well. So we're getting better at that. So the treatments in Parkinson's really are as a balancing act, treating the motor and the non-motor symptoms. And sometimes the treatments for motor symptoms can worsen the non-motor symptoms, and vice versa. Some of the non-motor treatments can worsen the Parkinson's. So we really have to balance these very, very carefully with individuals. So hopefully we will get into the phase that we are treating patients in a pre-symptomatic phase, and that's where a lot of the gene therapies, et cetera, are hopefully will be beneficial in the future. So we have to basically get better biomarkers. One of the hardest parts is that Parkinson's is a very diffuse heterogeneous disorder. There's multiple forms of Parkinson's. So one of the best things that we can hopefully hope for in the very near future is really a better definition for Parkinson's. So James Parkinson did a great job over 200 years ago in 1817, but we definitely do need a better definition. And back in his essay, The Shaking Palsy, he definitely put that challenge to us to come up with a better definition for this neurodegenerative disorder. And there is a preclinical phase, and there's a premotor, or what we call non-motor phase, and there's a motor phase. So I think as clinicians, as research scientists, we definitely have to continue to improve upon the definition and improve upon treatments for Parkinson's. So if we take a look at Parkinsonism syndromes or Parkinson's syndromes, the most classic one, of course, is the idiopathic Parkinson's disease, and that's about 85% of Parkinsonian syndrome. So what that means is if we give a replacement of the dopamine, the reduction that we see in Parkinson's, there's improvement in motor symptoms. That's what we call classic idiopathic Parkinson's. We got to rule out drug-induced Parkinsonisms. These are medicines that can mimic Parkinson's, a lot of the antipsychotics, some of the GI drugs, et cetera. There's multisystem atrophy, so these are more global disorders, more affected than just the motor symptoms, also the autonomic nerve system being involved. There's atypical Parkinson's, like progressive supranuclear palsy. We've learned that this is more of a tauopathy rather than an alpha-synucleinopathy. So the protein is different that is accumulating, and there are different features in progressive supranuclear palsy than Parkinson's. But about 1/3 of those patients may respond to some of the Parkinson's medication. Then there's vascular Parkinsonism. We have a small stroke in an area that can mimic Parkinson's disease. And then we have the chronic traumatic encephalopathy, what we used to call pugilist Parkinson. And again, that's a different protein. That's also a tauopathy. That's TDP-43. And we know from the last pandemic that we had, the von Eckmos encephalitis or encephalitic lethargica, patients who survived that last pandemic, they went on to develop a post-encephalitic Parkinsonism. So it's going to be interesting learning about COVID-19 and some of the sequelae that happens, but we're going to continue to learn, but we haven't had any post-encephalitic Parkinsonism since the 1960s, since the last pandemic in the 1920s. So when we look at Parkinson's is the second most common neurodegenerative disorder. So there's approximately 1 million people with Parkinson's disease, whereas Alzheimer's disease is the most common neurodegenerative disorders, and there's about 5 million individuals. If we don't find something to slow the progression of this disease by the year 2050, those 5 million Alzheimer's people are going to be 15 million people, and those 1 million people with Parkinson's disease are going to be about 5 million individuals. The reason why is that we are living longer. The longer we live, the higher the incidence of Parkinson's there is. So there is a real need in the scientific community to find disease-modifying therapies, and we've yet to do that per se, but we have modified the disease to a certain extent, but we really want to come up with better agents that could really slow down the progression of disease or prevent it from further progressing. So here, this is a graph that you can see that Parkinson's disease clearly increases with aging. You see the incidence increase with age, so that definitely is a risk factor. And again, Parkinson's is a very heterogeneous disorder. Both the environment and genetics play a role. For some people, the genetics is the main cause of Parkinson's. For other people, environment may be the main cause, but because of the genetics they have, they're more predisposed. So the same genetic, environmental factor may not cause Parkinson's in one individual, but another person with a certain set of genes, they're more susceptible to them. So there is a combination of genes and genetics that cause Parkinson's. And again, this is why Parkinson's is so heterogeneous. There's so many different disorders. If you look at risk factors for Parkinson's, having any relative or a first-degree relative or family history, there's a higher incidence of Parkinson's in individuals that do have a family history with it. Then you can see in this particular slide, there's other risk factors that you can see, like mood disorder, pesticide exposure, head injury, well water exposure, rural residency, upbringing. Those things can also increase the incidence of or increase the risk of Parkinson's disease. We've learned that coffee drinking is something that could reduce the Parkinson's in some people. And one thing that always shows up is smokers. But I always warn people that just in my personal experience, four of my grandparents were all smokers. They didn't live into their 60s. They lived past it, in their 60s is when they passed away. So they lived into their 70s or 80s. And now in my parents' generation, we're seeing a lot more neurodegenerative disorders that we didn't see in their parents' generation. So smoking may not allow you to live as long as you may have been able to live. So the risk for neurodegenerative disorder may not have been there because, again, age is a risk factor. So I don't really recommend smoking. So genetics and Parkinson's is an area of very, very much interest, and I do applaud for the work that the Parkinson's Foundation is doing in this particular category. Because of the Human Genome Project, we've identified several genes that we know are causative to the development of Parkinson's disease. One of the most common ones is the LRRK2, but we've also, because of the Genome-Wide Associated project, we've also have learned that the GBA is also a gene of particular interest. So we're learning more about specific types of Parkinson's, and I think in the near future we will see specific treatments for specific forms of Parkinson's disease. But yet there's still these other additional genes that are associated with Parkinson's, and again, learning how they influence Parkinson's and the environmental factors that people with these genes are more susceptible, I think are going to be of great interest. And it may be that how we approach these patients in the future could be different. So a person from GBA may be treated differently from a person with LRRK2, et cetera. So we're going to learn probably how best to treat them, different treatments, and maybe people respond differently to different treatments. One thing that has also helped us along the way over the last decade is the fact that we have neuroimaging capability now to look at the dopamine concentration. This is known as the DAT scan. If you can look at the top part of the slide, that's a person with essential tremor. So they don't have Parkinson's, and you see they have the normal uptake of the comma uptake of the dopamine active transport, showing that the dopamine concentration, the dopaminergic neuronal concentration is relatively normal in that individual. And right below there, this is a 37-year-old with Parkinson's disease. You can see a significant decrease in uptake on his left side of the brain compared to the right side is much worse, and he has more symptoms on the right. So again, this is a scan that can be used to look at the dopamine concentration, especially if there's a difficulty in making the diagnosis of whether somebody has essential tremor or the Parkinson's. This is one of the classic ways that you can do it. It can help you differentiate between drug-induced Parkinsonism and true Parkinson's disease. And again, we're learning how to use this, hopefully, to follow patients along the way. But again, we still have a lot to learn. But again, it's a tool that we definitely do have that can be useful in some patients. So one question that I often get, does Parkinson's change the course of Parkinson's disease? So a lot of times we have patients who they just got diagnosed with Parkinson's, the symptoms are quite mild, and sometimes they don't know whether or not they should be taking medications or not. But we've learned over the course of time that Parkinson's treatments have changed the course a little bit, and I think to the better, especially to improve the quality of life of our Parkinson's patients. But if you look at survival prior to the availability of levodopa, so before the 1970s, In this particular graph, you can see that the lifespan of Parkinson's patients was well below that of the general population. However, after the 1970s, once levodopa became available, the life expectancy of patients with Parkinson's was equal to that of the general population. So to me, I think definitely treating Parkinson's, I think, has made a difference in the survivability of Parkinson's patients, but also, as you'll see with the next few slides, also when you look at disability, the disability is definitely lower in patients who receive treatments compared to those who do not receive any treatments whatsoever. So this is one of the earlier studies back in 2004 through the Parkinson Study Group, and this is known as the L-DOPA study. And you can see clearly here that the disability just over 42 weeks continues to increase in the placebo group of patients within 2 years of the diagnosis of Parkinson's who receive no treatment compared to patients who receive classic carbidopa, levodopa, 150 milligrams a day, 300 milligrams a day, or 600 milligrams a day over 40 weeks, and then they were withdrawn for the last 2 weeks. So there was a withdrawal phase, and then even after the withdrawal phase of 2 weeks, the placebo group was still worse off than any of the treatment groups. One of the things that we learned that people were receiving 600 milligrams a day, there was definitely more of motor fluctuations in those groups with wearing off and dyskinesia. So you always want to try to find the lowest amount of medicines, but you can clearly see that the disability is much lower in patients who were on treatments compared to no treatments just within the 40 weeks of treatment here. So again, levodopa is one of the best medicines that we do have for the motor symptoms of Parkinson's, but we've also seen very similar studies with dopamine agonists. So Pharmacological, we've seen that the disability is much lower in people who are on treatment compared to those people who were on placebo. And we also saw earlier studies that maybe the dyskinesia were a little bit worse in people who received levodopa first rather than a dopamine agonist first, ropinirole, in these particular studies. So definitely medications do play a role in treating Parkinson's. And then we saw with earlier studies in patients who received the monoamine oxidase B inhibitor like rastagalin compared to that of placebo, at the end of 6 months, they were no worse off compared to that of the baseline, whereas the people who received no treatment continued to worsen during those 6 months. So our medications definitely do make a difference for patients, and there is argument to treat earlier rather than wait. And one of the reasons why, especially in the 80s and 90s, maybe there was let's wait until people get really bad before we start to treat, was because we only had like one treatment back then, or very few treatments. And this is where I'm going to be spending some time with you today to show you all the different treatments. We have over 30 products for Parkinson's nowadays. So the trick is to find the best medicine that works for you, working with your physician to try to find the best medicine to help you out, to improve the quality of your life, to be able to treat the motor symptoms. That's what we aim to talk a little bit here today. So we're going to talk about a lot of different medications. And, you know, the bottom line is that I can probably give a 1-hour lecture on each of the medicines that I'm going to be talking about. So I'm going to give you about a 20,000-foot view where we are in Parkinson's today, all the different treatment options that we have, so that you can go back and you can talk with your health provider about what's the best medicine for you. Because what works for Mr. Jones may not work for Mrs. Smith. So everybody's a little bit different. And what's a saving drug for Mr. Jones, Mrs. Smith may have side effects and may not be able to tolerate that medication. So everybody's a little bit different. And I think it's very important to individualize the treatment for Parkinson's patients. So if we take a look at our treatment options, we still really don't have any preventative treatments or any true what we call disease-modifying therapies yet, like we have like in multiple sclerosis. But I think there's a lot of great work being done in research, and I don't think we're too far off of really identifying true disease-modifying therapies in the near future. When we take a look at symptomatic control, that's where we really have done a very good job, both with pharmacological treatments and surgical treatments. And again, we'll talk about those today. Non-motor management is also something that we continue to do a lot of research, and we see new treatments for the non-motor symptoms of Parkinson's coming out almost every year. So we're doing a very good job there. Again, restorative, and this would be for slowing down the disease or restoring function, transplantation of stem cells, certain types of gene therapies in the future, neurotrophic factors. Again, still a lot of active research there, but still no definitive FDA-approved treatments today. So let's take a look at the drug classes. We have a lot of drug classes in Parkinson's. We have levodopa-based, so this is the precursor to dopamine, and then we have a lot of drugs that help levodopa. Those are the COMT inhibitors, MAO-B inhibitors, and now the newest class, the A2A antagonists. And then we have other medicines that mimic dopamine. These are the dopamine agonists, so they mimic the action of dopamine. And then we have another class of medicines like anticholinergics and amantadine. And again, we're going to talk about them. So there are a lot of different sites of action of these drugs. There's drugs that work more in the periphery and those drugs that work in the central nervous system. So again, this slide just throughout my career has grown substantially over the last 20 plus years. So what this slide brings to me is that there's a lot that I can offer to patients depending on what's going on to improve their function, to improve their on time, to reduce their off time. And we'll explain what those terms mean throughout this presentation. So the first class of drugs that we really had were anticholinergics. Trihexyphenidyl, also known as Artane, was the most common one. And this can really, what this does, it blocks cholinergic activity, a neurotransmitter called acetylcholine. And what you're going to learn from today's talk is that we are modulating more than just dopamine. There's a lot of neurotransmitters that are involved in Parkinson's. It's not just all about dopamine. So we have dopamine, we have acetylcholine, we have serotonin, norepinephrine, and adenosine. These are all these different neurotransmitters and these different chemicals we can modulate to help improve Parkinson's. So you're going to see all these different drugs attacking different neurotransmitters to help improve function in some way for our Parkinson's disease patients. So if we take a look at the anticholinergics, they block the overactivity of acetylcholine that comes out of a place called the indirect pathway when you don't have enough dopamine, and that can help control tremor and rigidity. But there's side effects with that. Sometimes it can cause a lot of dry mouth, sedation, confusion, hallucinations, constipation, etc. So these were some of the first drugs that we had, but a lot of our patients don't really, sometimes can't tolerate these medicines to a very large degree. Some of our younger patients can tolerate it better, and we use it also in dystonia. Amantadine was the next drug to come out. It was actually an antiviral agent. I call it, it was almost like the original Tamiflu. So it was for influenza A. And patients who got influenza A, they noticed that they had improvement in tremor, rigidity. We've also learned over time that they had dyskinesia. Now, we have, recently, we've seen new long-acting formulations, and sometimes just changing how the drug is delivered, sometimes that improves the previous medications because now the drug delivery is different, and sometimes we see better control. And we've seen now long-acting formulations, especially Gocovri, we've seen it be a little bit different than the original amantadine. Now there's also a generic long-acting called Osmolex that we're still learning about. But again, these medicines can sometimes really help our patients. So we will see new formulations, and instead of taking medicines multiple times a day, maybe just once a day, just for example, the Gocovri is a great example of that you take in the evening, and then in the morning, that's when it becomes therapeutic and is therapeutic throughout the day during your awake time. So we're learning how to deliver some of our older medicines better, and this we see better improvements in on-time, reduction in off-time, and improvement in dyskinesias with a drug like Gocovri. So these are definitely things that are available for our patients now. So the mainstay has been carbidopa levodopa. The original name of this is Sinemet, and that's actually just Latin for without vomiting, Sinemet. So this was actually the birth of rational polypharmacy, putting two drugs together. If you look at the original movie Awakenings, you'll see that you have to give 1,000 to 1,500 milligrams of levodopa at each dose 3 times a day. You put it together with carbidopa, now it prematurely change over to dopamine in the periphery. So here you'll see here the metabolism. So the carbidopa prevents the peripheral AADC, that's aromatic acid decarboxylate converting enzyme. So if you block that, more levodopa gets into the brain, so you can change it over to dopamine. And then you also prevent a lot of the side effects. So you prevent the nausea and the vomiting. And that's why you got the name called Sinemet, without vomiting. But you also got to be able to give, instead of 1 gram, 100 milligrams and be more effective. So this is the birthplace of rational polypharmacy. We'll talk a little bit about COMT inhibitors or MAOB inhibitors a little bit later, but we've seen various formulations come out. We have immediate release and controlled releases. We saw in the 80s and early 90s liquid levodopa being done, but now we have a true long-acting one. The original carbidopa levodopa controlled release is in a wax matrix, and it doesn't always dissolve and doesn't work as well. It's a Class C drug according to American Academy of Neurology because it doesn't always work very well. But now we have a true long-acting one, IPX066, also known as Rytary, little beads that dissolve immediately at 2 hours and at 4 hours. So it really is a much more long-acting. We may even see better ones than Rytary in the near future. Then we also have a pump that delivers a carbidopa levodopa enteral suspension right into the small intestine. So it's a nice, true, continuous drug delivery. And for patients of mine who do get this, it's one of the best ways, I think, to deliver carbidopa levodopa right into the small intestine to bypass the stomach, etc. And this has been very beneficial for a lot of our patients who have received it. Now we're seeing other ways to bypass the gastrointestinal system. So with levodopa, so now we have a new drug called it's an inhaled levodopa. It's known as Inbrija, so it's an inhaler. It's an on-demand therapy, and this on-demand therapies are kind of changing the way that we treat Parkinson's. So it's not only just about a maintenance drug, but when the maintenance drug isn't working, we have an on-demand therapy to help patients during these off episodes when the medicines aren't working. This drug can be used up to 5 times a day. In clinical studies, people used it up to twice a day. About 99% of our patients were able to do it when they were in the off state. And again, it bypasses the GI system. So now we have at least 2 on-demand therapies that can allow us to think about treating Parkinson's a little bit different, not only about the maintenance therapy, but when a patient becomes off, to offer them a treatment that they can use on demand when they need it, and it bypasses the constipation and the gastroparesis that is very common in Parkinson's disease. Now we're going to go to a different class of medications. These are MAOB inhibitors. The original one was selegiline. Then we had rasagiline that seemed to be a little bit more potent once a day. And again, I showed you a study earlier with the Tempo study. And now we have a reversible MAO inhibitor, sulfonamide, very popular in Europe, a lot of work being done, whether or not it can have an NMDA blockade beneficial for dyskinesia. It's also once a day daily. But again, these medicines help augment the action of the levodopa because it stops the breakdown of dopamine in the central nervous system, so you can recycle and reuse that dopamine and hangs around a little bit longer. So we see that it definitely does have an advantage of using these MAOB inhibitors to give you more on time and less off time. And then one of the newer classes are the acetylmethyltransferase inhibitors, and these medications also complement levodopa-based medications because it stops the premature breakdown of levodopa into a compound known as 3-methyl-dopa in the periphery. So again, making levodopa more potent, giving you less off time, more on time. we have 3 classes there, and we're going to talk about them here. The third one is still not available in the U.S., but it is available in Europe. It's called opicapone. It's a once-a-day drug. So again, here we talked about the acetylmethyltransferase inhibitor. So we stopped the breakdown of dopamine prematurely in the periphery, so more levodopa gets in through the blood-brain barrier. There are some acetylmethyltransferase inhibitors, for example, tacopone, that can work in the central nervous system, again, keep dopamine around a little bit longer. And again, we talked about the monoamine oxidase B inhibitors that can stop the breakdown of dopamine to keep it around longer and give you more on time, less off time. So again, this is all part of rational polypharmacy, and these are great supporting agents to a drug like levodopa. So tacopone was the first COMT inhibitor in the U.S. There was a lot of side effects with acute fulminant hepatic necritis. So there's an FDA warning, you have to have a lot of liver monitoring. So it's not a very popular one used, but it's still around. Entacapone, also known as Comtan, has been around for a while. And the biggest side effects are diarrhea and bright orange urine sometimes, but it can give you more on time, and you have to take it with each dose of carbidopa, levodopa. And there are formulations that combine levodopa, carbidopa, and entacapone all together into one. You may have heard of a drug called Stalevo, that's now generic, back in the early 2000s, that does combine all 3 agents together. And then dopamine agonists. So these medicines mimic the effect of dopamine. So the way that these drugs work is that these drugs are usually given once a day, but there's some that are 3 times a day, and there's some that could be injected, and there's some that are maybe coming out in pumps, and there are pumps with dopamine agonists available in Europe. But again, these directly stimulate the dopamine receptors, so they don't have the dietary problems or the fighting with the amino acids with the proteins that we see with levodopa. So the gut system isn't always a problem with these, especially if they're delivered in a patch form or in or injectable form, or in the future we may see pumps that are subcutaneous pumps. So we have different types of dopamine agonists that have been around, but the more common ones that we currently have are medications like pramipexole, ropinirole, apomorphine injection, and rotidogene. These are really the main dopamine agonists that we currently have. We do have once-a-day formulations of pramipexole and ropinirole, and we have apomorphine injections as a rescue drug, and then rotidogene is through a patch, is also known as Nupro. So these are other ways to deliver medicines as well. The most common side effects are nausea, vomiting, dizziness, but you also, with all dopamine agents, this one a little bit more, but all dopamine agents, you'll see us as neurologists always ask about impulse control disorders. You know, is there excessive spending of money, hypersexuality, pathological gambling, just a lot of shopping, a predilection to a lot more sweets than normal. So sometimes dopamine agonists can have some side effects in some individuals that we may not be able to use them. Apomorphine is probably the original on-demand therapy, subcutaneous injection, really only available in the U.S. This drug is known as Apoquin. Again, this could get you back on usually within 10 minutes or so, and it is probably one of the most potent dopamine agonists that we have, almost as potent as levodopa. Nausea, vomiting, low blood pressure are some of the side effects associated with it, but right now in the U.S. is only available as an injection, and again, it is an on-demand therapy that can help people for when they turn off to turn back on. And there's been some nice work with early morning akinesia with the use of apomorphine injection that was known as the AM Impact study. What we may see in the very near future is the use of sublingual apomorphine. So this will be another on-demand treatment for off episodes, still not FDA approved, but you put different dosages, is again, and specific for patient underneath the tongue, and a person will turn on in about 10 minutes or so, and we've seen the effects last up to about 2 hours in clinical trials. So we will see what happens in the near future, but again, this will be yet another drug for on-demand therapy. And again, this is really changing how we approach Parkinson's, so that we have the maintenance therapy and then we have an on-demand therapy. And we see that in headache, for example. For a headache, we give drugs to prevent the headache, and these are your baseline drugs. And then we have abortive drugs. When the migraine headache comes, they take an abortive agent so they get rid of the headache, so they don't let it linger on. And the sooner they use it, the better they're off, our patients who suffer from migraine headaches. So in Parkinson's disease, having a drug to be able to treat the symptoms of Parkinson's, but if that maintenance drug, it doesn't work as well, or you have an off period, off episode when the drug isn't working, now we have on-demand therapies to help our patients continue to be able to modulate or reduce those symptoms that can interfere with their quality of life. So we've seen pumps come out. So this is what we call as a duopa pump, or the levodopa, carbidopa intestinal gel, the carbidopa, levodopa intero suspension. This is the pump that goes directly into the small intestine. We're going to probably see better formulations of carbidopa, levodopa in the future that may be subcutaneous, so you may not need a infusion right directly into the small intestine. The apomorphine pump, this is what's available. It almost uses the same type of technology our diabetics use with insulin. We'll hopefully see this in the near future with a drug like apomorphine as well. And again, we talked a little bit about dopamine agonist patch. So we can deliver dopamine agonist transdermally, and this is what's known as Nupro. The nice thing about it is once a day. It has a nice long-acting profile, and it's available both for Parkinson's disease as well as restless leg syndrome. And again, the same side effect profile as dopamine agonist. Our newest class of drug is the A2A antagonist. So istradefylline, 20 milligrams or 40 milligram once a day daily, was approved in the U.S. back in August, and it basically started to become available in our clinics in October of 2019. It's been available in Japan for approximately 7 years now. And it's showing us as neurologists and movement disorder neurologists that Parkinson's is more than just modulating dopamine all the time. So this works on blocking these receptors that interfere with function of movement through a chemical called adenosine. What we've learned is that the A2A antagonists increase, especially in an area called the indirect pathway. So when you don't have enough dopamine, what happens is that the direct pathway is not effective. That's like your gas pedal in a car. That's what gives you movement. So that's why we've always treated Parkinson's. We give levodopa, give you dopamine agonists. We try to stimulate that gas pedal stepping down. So we try to stimulate the direct pathway, and dopamine will inhibit the indirect pathway. But there are these receptors on the brake pad, the A2A receptors, and they start to build up as Parkinson's continues to progress. So that's why we're always giving more levodopa, more dopamine, et cetera. But now, for the first time, we have the ability to block these receptors on the brake, to take that foot off that brake, so that whatever you are already giving, like levodopa, works better, and that gas will go. And that's what we've seen so far with the A2A antagonist, that it definitely helps with reducing off time and increasing on time. The nice thing about it is a once a day, and in our clinics we've seen some good tolerability, and that's kind of what we're seeing in the clinical trials. And there's 4 well done clinical trials, 2 in Japan and 2 in the United States. So we're learning about modulating A2A antagonists, and it's a very exciting time, I think, in movement disorders and in Parkinson's, yet again modulating a different neurotransmitter than just dopamine. So some of the side effects that we can see, if you give too much gas, you can get dyskinesias. Some people have some dizziness, constipation, nausea, hallucinations, insomnia that we're seeing in clinical trials at a lower rate. Dyskinesia is really the main side effect that I remember from the clinical trials, but it's seeing some good tolerability in our clinics. So it is yet an exciting time, and we may see other A2A antagonists in the future as well. So Non-motor treatments, again, this is where a lot of active research is still going on. So about a third of our patients have orthostatic hypotension that when they go from a lying to a standing position, they drop over 20 millimeters of mercury. And you can see sometimes people they're hypertensive lying down, and they can go to like a 70/40 blood pressure standing up within 3 minutes. And this could cause a lot of fatigue. This can people just don't have the energy to do things, and some people pass out. So we have drugs like droxidopa that have been approved for the neurogenic orthostatic hypotension, and this is the precursor to norepinephrine. So again, a lot of patients with orthostatic hypotension, again, about a third of patients with Parkinson's, are deficient in norepinephrine, and again, droxidopa can be very beneficial for them. Off-label, we could use drugs to increase salt intake. That's fludrocortisone, also known as Florida. Midodrine is off-label use. So you got to be careful with the supine hypertension, but that can help raise the blood pressure. And off-label, we use drugs that we use in neurological disorders like myasthenia gravis to increase acetylcholine. Paracetamol can also be used as well. But conservative measures are very important. Waltz, increased salt intake, compression stockings, abdominal binds can be helpful too for orthostatic hypotension. But again, we'll see new drugs hopefully come in the near future for orthostatic hypertension. A lot of activity in clinical trials as well. And in orthostatic hypertension is also a big problem in our patients with Lewy body disease. And I think we see that even more common in Lewy body disease than in just Parkinson's. So hallucinations and delusions in Parkinson's disease-related psychosis. I think we've really seen a lot of benefits with the use of pimavanserin, also known as Nuplazid. Here, we're not touching the dopamine system at all. It's blocking the same receptor that LSD acts on. It's the 5-HT2A receptor. And we see patients with Parkinson's that the 5-HT2A receptor increases in those patients who have hallucinations and delusions. So the nice thing about this particular medicine, we've seen that it doesn't worsen the motor symptoms. So this has really changed a lot of us in movement disorders. That's becoming more and more a first-line drug. You know, we have an older drug called clozaril or clozapine that we've used in the past that also is there, but we need daily blood tests, and it's also been helpful for our patients with hallucinations and delusions. But again, that weekly blood draw, it can be very hard in some of our patients. Off-label, we use drugs like Seroquel, but they really, although they can be relatively safe in Parkinson's, they haven't done the job that these other drugs have done in clinical trials. So again, we'll be learning more and more about the modulation of 5-HT2A in this population. And again, these are new treatments that really have helped our Parkinson's disease population. And again, no drug is 100%. But again, these are the drugs that have been beneficial. In the last 2 years, we've seen both Xeomin and Myobloc. These are botulinum toxins that have been FDA approved now for drooling or sialorrhea. So this is yet another treatment for non-motor treatment. We've also have had treatments that block the breakdown of acetylcholine to help improve mild cognitive impairment or dementia. The rivastigmine or the rivastigmine patch, also known as Exelon, when it was trade, now it's available generic, that one has the indication in Parkinson's disease dementia. Off-label drug like donepezil or Aricept can also be used in our patients. For REM behavioral sleep disorders, we use drugs like clonazepam and melatonin. And constipation, urinary urgency, sexual dysfunction, a lot of challenges with this very multifactorial, and we still need a lot more studies. But we're seeing some agents actually, like an agent known as Interin in clinical trials that look very exciting, and we're eager to see what the phase 2, phase 3 clinical trials show in constipation, but and specifically for Parkinson's patients for constipation. So we'll see what that shows in the near future. Surgically, you can have a whole entire lecture series just on DBS. Deep brain stimulation, we have seen improvements in the Medtronic one, advances in Medtronic, Abbott, and Boston Scientific. So this is a lot of advances being done with all the 3 devices, and again, very effective in improving our patients' function, reducing off time, improving on time, etc. So this some important, because we see a lot of the drugs are looking at improving off time. So these are some of the types of off times that you can see. Wearing off is that the medicines are not lasting as long as they did before. You used to take your medicine every 5 hours or every 4 hours, but at the 3 or 4 hour mark, now you're starting to see a reemergence of symptoms. So this is known as wearing off. Sometimes we just turn off and we just don't know why. This is called the on-off phenomenon. Sometimes we can see a delayed on. So you used to turn on and usually 15, 20 minutes after taking the medication. Now you're waiting 45 minutes, 60 minutes, 90 minutes, 120 minutes for the medicine to finally kick in. But a lot of times that has to do with gastrointestinal problems. Or sometimes you take the medicine and you never turned on. That's known as a dose failure. And some of the most common signs of wearing off or of an off period, again, a lot of people can note that you can have tremor or slowness of movement or muscle cramping, but some of the symptoms may be non-motor. So you can have pain because you're having the cramping. Some people have an anxiety. Some people feel like they have a brain fog. They don't think as well. Some people can get very irritable. Some people can start to drool. Some people can get short of breath. So numbness, pain, tingling sensation. So again, it's very different from every individual. So it's important to know, so this is a very important slide because it helps you talk with your physician that your medicines may not be lasting as long or you're having off episodes, that motor and non-motor symptoms can accommodate an off episode or an off period. So what do I see in the future? Hopefully we'll see new definition. We're going to see different types of gene therapies and different clinical trials still going on. I talked a little bit about the subcutaneous pumps for levodopa. That's AbbVie's in development of one called 951. Very exciting. Opicapone is a once-a-day COMT inhibitor available in Europe. Hopefully we'll see that in the U.S. Hopefully we'll see the sublingual apomorphine sometime this year. And we'll see newer formulations of levodopa are in clinical trials, maybe lasting a little bit longer. And I talked a little bit about the constipation studies with Interin. There's been a lot of controversy with nilotinib. We at Georgetown did a clinical trial, and we saw a lot of very good signals that I think could be beneficial. The difference in the studies was that we have followed patients for over 3 years, whereas the Michael J. Fox study just only looked at really the first 6 months. And it's after the 6 months that you see the benefit. So I think it was a little bit of premature of the Michael J. Fox Foundation to say, oh, there's no benefit with this drug. But they have other interests in other kinase inhibitors. So I think kinase inhibitors may be an answer, I think, in neurodegenerative disorders. And we've actually seen some very nice preliminary work in Alzheimer's disease as well, and our paper hopefully should be coming out in the near future. But there's other protein kinase inhibitors like bosutinib. We also have discovered new ones at Georgetown called juutinib, and there's others that are being studied by Sun Pharma, K0706. So I think a lot more to come in the future. So it's not over yet. I think there's a lot of interesting data that you'll see over the next couple of years come out, especially in the protein kinase inhibitor field. So in conclusion, what I'd like to say is that we have multiple medicines. Talk with your physician. Talk to them about the symptoms that you're having, and you'll find the best medicines for you as an individual. Polypharmacy is really, or what we call rational polypharmacy, can be very beneficial. And remember, it's a team approach. So it's not only seeing your physician, it's also seeing your allied healthcare professionals, physical therapy, occupational therapy, speech therapy, psychiatry. We're all here for you. We all work together. And again, I'd like to thank the Parkinson Foundation because they definitely are the model about bringing this multidisciplinary approach and continuing to challenge us to help improve the quality of life of our patients with Parkinson's disease. Thank you.
Thank you very much, Dr. Pagan. That was a fantastic talk that you provided, really rich with information. And just want to remind our audience that if you weren't able to get everything, which I can certainly understand, these slides are available for download. So you can download the slides. I especially like the one Dr. Pagan presented on how to talk with your physician, the words that they might better understand to help describe your symptoms. So if you go to the chat down at the bottom, it's now highlighted in orange. My colleague Camila has put the link there again for you to download that. And what I think we're at the top of the hour, and Dr. Pagan, if you have a few more minutes, I would love to be able to answer some of the questions that have come in, and there have been a ton. People have been rapt listening to you.
I would be happy to answer more questions, yes.
Fantastic, that's great. And just highlighting for our listeners, we have Parkinson's Awareness Month is going on right now. April is a noted month to just bring awareness for PD overall, and here's a calendar for different activities. So first question, you know, you touched on this a little bit, Dr. Pagan, but and I think you got the answer, but just to be clear, because I think there's still, you know, a lot of confusion about this, and that's why we're seeing some of these questions come through. But the best time to initiate PD medications. You know, some people are concerned about dyskinesias. There's the old story about you need to save the big gun for later. It sounds from you that that's all kind of, you know, in the past. What do you say?
I think it is in the past, and I think really we have to look at the individual. What's going to be the best medication for the individual? It definitely depends on the disability. But if you can get away with a once-a-day medication like an MAO-B inhibitor or once-a-day dopamine agonist, again, that may be better than starting off with levodopa that can be 3, 4, or 5 times a day because of the short activity of the life, the half-life of that drug. So we have to look at individuals. I mean, if I have a patient who I'm seeing for the first time has a lot of tremor, and let's say they're a surgeon, levodopa may be the first drug that I use for that person to keep them active and be able to keep them operating, etc. So everybody's a little bit different. I think you have to take it. The main thing is to not avoid taking medicines, because I showed you in all the classes of medicines, and there is a study by Grosset from France that looked a treatment versus no treatment, the health status of the individual is much better in the people who at least took one drug versus no drug. So I think that wait and watch approach is definitely in the past. And again, we have so many different medicines, and as things advance, we can change the treatments and we can get a little bit more aggressive. So you can see. So I think if you are diagnosed with Parkinson's, find out the medicine that's best for you. We always want to use the least amount of medicine, but I think it's very important for you and your physician to find out what's going to be the best medicine for me. And I think that's what's the most important. And now you have this information about all the different drugs. I gave you the 20,000-foot view, so go back and take a look at everything, because there's a lot of information in those slides that I didn't go through, but Parkinson's is very variable, but there's a lot that we can do for you.
So I think you bring up a really good point, and you know, that's my next question that's come through is, what's the best way to talk to your doctor to optimize your medication? So whether you're newly diagnosed or you've had PD for a couple of years, I mean, I think the great list of words to help describe symptoms is a good start, but what would you suggest for someone who's coming in to visit their doctor, how to get that conversation going so they can really be working at where they want to be in their quality of life?
So I think it's, you know, are the drugs adequate? Are you having a good quality of life? Are you able to do the things that you want to do? Are you waking up and you don't feel very good and you're waiting 2 hours before to get your day started? If that's the case, that's something to have a discussion about. Or just after every meal, you can't walk it for the next 2 hours. So look at how especially that week before you go see your doctor, see how your medications are behaving and how you're responding to the medicines that you're taking. Are they adequate enough to give you a good quality of life? Yes or no? And where are the problems? So, and you know, sometimes the problem lies in constipation, you know, that the person is so constipated, the medicines aren't working, you know. So all of these things are really important. And now that you know that there's both motor and non-motor symptoms, that it's okay for you to talk to your doctor about your sleep. It's okay to talk to a doctor that you may be seeing things or feel like people are around. Or it's okay to talk to your doctor about your mood, anxiety, or pain. We're here for you for those things. And that's what Parkinson's has, all those features associated with it. So talk to them about where we can help you improve the quality of life. And again, we'll probably ask a lot more questions once we hear certain terminology or certain complaints from an individual, but we're here to help you.
Absolutely. I think that's a really good point. And, just you bring up this issue of constipation, just want to highlight for our audience that, the Parkinson's Foundation website has a lot of useful information, including a really good, helpful fact sheet put together by experts, nurses and gastroenterologists to help people work with their physician and do things at home to help with constipation. You mentioned food. Oh, yeah, sorry, go ahead.
No, and I was going to just echo that. It's an 8-page PDF, and we hand it to our patients on a daily basis. It's a fantastic review of constipation, and oftentimes for some of our patients, it may be a cocktail that they need to get through that constipation. And a lot of times that can help the medicines be more effective.
Yeah, absolutely. I do remember an X-ray that a physician presented at a conference showing where, because of the constipation, you could see the actual medications that people were taking because they hadn't been able to pass through their GI system, and so they were not getting any benefit, and it's a real issue. When taking medications, you mentioned about meals. Is it just Cinemet that you have to worry about taking around food, or is there other ones as well?
So the levodopa definitely is the main one, but some of the controlled release medicines, especially if there's a lot more slower, they may be more powerful or they may not work at all. So constipation definitely does play a big role in the medicines. But again, if you're using an injectable, if you're using potentially in the future a sublingual, or if you're using a transdermal patch or some of these pumps, it's less of a problem. So again, that's constipation. I think is probably one of the biggest factors, I think, in affecting the response to medications. About 80% of our Parkinson's patients have constipation, but maybe only a third really even complain about it. Because again, they've had it for so long that they just think that's their normal bowel routine. So I think this is a big issue, but the levodopa-based medicines are definitely the main ones that cause the biggest problem with constipation in foods.
Yeah, thank you. And I just want to mention our sponsor, Kiowa Kirin. We just had the slide up there a few seconds ago. I just want to thank them again for their sponsorship. And just a reminder for those individuals who are looking for CEU credit, again, check the chat. And I want to mention that we've got we've got some new partnerships together, and one of them is with AARP, and we have some information about that as well for you to see. We're going to be doing joint webinars with them, and it will be a wonderful resource to reach a broad audience. And for people who have questions that aren't being able to get through today, because we are running short on time, and thank you again, Dr. Pagan, for spending some extra time with us. Please call our helpline, 1-800-4PD-INFO. That's 1-800-4PD-INFO. And again, if you had a cutoff earlier, your friends had a cutoff, this is being recorded. We'll be able to watch it on demand in about 2 days' time, and that's you'll receive an email. Last, I just want to mention we've got our next round of webinars coming up on Tuesday, June 9th in 2020. It's about being newly diagnosed, living your best life with Parkinson's. It's going to be another virtual webinar as part of our Health at Home series, so we're looking forward to that. Just two more questions, if I may, Dr. Pagan, just recognizing we're running low on time. Many people are, when they look at the medications, they're looking to solve particular symptoms with them. People with young onset Parkinson's disease, for instance, or even some of those individuals who wake up in the morning are often dealing with dystonia. What's the best approach to deal with that? Is it DBS? Is it botulinum toxin? Is it getting the medications right? What is your approach to dealing with that?
So again, I think it all depends where you are with the course of the disease. I think definitely people who have early morning off, or they're waking up with a lot of dystonia, a lot of cramping, they're waiting for a long period of time for the medicine to kick in. These are where sometimes the on-demand therapies could be very beneficial, because if you were to inject or put something sublingually or maybe inhale levodopa, any of the three, that may turn you on a little bit quicker, and that may be able to get your day going. That you still take your medicine. So I think that's anybody. Again, DBS is something that could be very helpful because deep brain stimulation gives you more on time, less off time, and you can get by with less medication. So sometimes that could be helpful. If it's very focal type of dystonia, sometimes botulinum toxins can be very beneficial. That's an off-label use, but it's something that we use quite often. Again, I couldn't talk about every single therapy, but botulinum toxins can be very helpful, especially in the calf muscles, to help people if they're having a lot of neck pain, cervical dystonia. That the botulinum toxins can be helpful there as well. So there's a lot of different treatments. Again, talk with your doctor because there's so much that we can do for you.
And the last question, I just think it's useful because we've got a lot of very interesting medications. You mentioned over 30 and many of the new ones coming on the market. It's an exciting time. Some of these on-demand therapies, my understanding is you've got maintenance medications like carbidopa, levodopa, and then when you are in an emergent situation, like you've sudden off time or having some trouble with something, that's when you use your inhaler. Just like you're an asthmatic, you don't use your inhaler all the time in place of your normal therapy. It's to help your normal therapies. Is that correct? Because some questions coming through suggesting that people are using it all the time.
Well, no, you don't use the inhaled therapies all the time. So you want your maintenance medications, and when your maintenance medications don't work, that's when you use these on-demand therapies. So you can't just switch over to just inhaling the levodopa all the time. You'd be doing that about every 1 to 2 hours, and that's just pure levodopa. So it works best with being on a carbidopa levodopa formulation already. But the beauty about these drugs is that they allow you to have more control of your symptoms because you don't always know when this is going to happen. Let's say you're out with your grandchildren, you have ice cream with them, and all of a sudden you start to freeze up. Now you can inhale it. And again, that's going to bypass the GI system. That's the beauty of it. You inhale it, it's absorbed through the lungs, and then you're able to turn on. Or if you're able to give yourself an injection, again, you're going to pass the GI system and you turn right back on. So that's the beauty of these on-demand therapies.
Dr. Pagan, thank you very much for your time today. Thank you to our Parkinson's community for listening to us. There will be, as you exit, there will be a survey to ask your thoughts on the webinar. I'm sure they're going to be fantastic. Don't mean to bias anyone, but Dr. Fernando Pagan, Georgetown University Hospital, Parkinson's Foundation Center of Excellence. Thank you very much for your time and telling us about the latest in medications today. Have a good day, everyone.
Thank you.
Bye-bye.
Thank you for having me. God bless. Bye-bye.